that I usually face is after students are through their proposal and collect data, they jump to the analysis part. And I don't know why, but data management part is not covered at all, even at schools like, I don't know about the PhD program, but in master's program, they don't cover data management, but it's a very important and critical aspect of research undertaking. And it's something that we all should do, and we all should be aware of. So in this lecture, we're going to cover what data management is and what its components are. So data management is, it's a process that lies after we collect our data. What we have is just simply a spreadsheet of an information of like 300, 400 patients. Between that and making meaning out of the data, which is analysis, we have to do a few things. We have to code our data, we have to clean it and validate it. We have to store it in a proper storing site so that we can get it back anytime we want. Especially storing it is very important because for publication, people usually throw out their data after conducting the research and finishing their report. But when we publish our research works, there is, especially nowadays, it's becoming universal. The journals will ask our de-identified data. So if we don't have the data, they will assume it's just fabricated data and they will not publish it. So it's very important to store our data, even if it's like something that we have conducted years back. So after that, we have to process and organize it. And it's only after these processes that we should go to the analysis part, doing the frequencies, the percentage, the measure of association, our odds ratio, and other stuffs. So it's very important to do these things. And data management can be conducted in almost any of the softwares that we know, including EPinfo, Spaces Data, and SAS and R softwares. So let's start with data coding. Data coding is simply it's a process of grouping our raw data into different groups and assigning codes to it. So why do you think is necessary to do grouping of our data and assigning code? Can anybody tell me? You can inbox it. So what's the relevance of coding our data? So the first part of data management is coding our data, giving it codes like zeros and ones and twos. So what's the relevance of doing that? Coding, most people are not comfortable doing the coding using the softwares and others. So what's the relevance of coding if it bothers the researcher? What's the necessity of doing it? Is it really critical? What's the necessity of coding our data? Okay, maybe for the sake of time, I'll proceed. So the purpose is, thank you, is really recognizable by the software. Thank you. Yes, our statistical softwares, they read numerical codes rather than just the non-numerical information. Let's say if we have gender information and we give it we label it as male and female, we can run some of the analysis like frequency distribution or cross-tabulation, but when we start to run higher tastes like even t-taste or regression analysis, our software demands codes rather than non-numerical data. So we have to label the female and male as 1 and 2 or 0 and 1 or whatever codes that we're interested in. So it's for the purpose of analysis. So when we code our data, which is our data means it's a response for our study variables. So our study variables can have two different types of natures. So based on that, our coding also depends on that. So the possible type of questions that we encounter depends on the type of variable our study contains. The first one is categorical variables, the other is numeric. For the first one, there are 3 possible types. When we are using a structured questionnaire, that means we have already coded the question even before collecting the data. For example, gender. We know that we have only 2 possible responses, at least in Ethiopia. So we're comfortable labeling it as 1 and 2, and we don't give it any other partly open-ended options because we have exhausted all the options and all the answers are going to fall within these 2 codes. The other is partly coded questions, which is when we're using semi-structured questions. For example, if we're studying drug adherence of some chronic illness, and if we're asking drug discontinuation reasons, we can have these options from what we have observed and from what we believe that could be a frequent responses. We can design this, and I mean, we can say drug side effect, unavailability of the drug, cost of the drug. We're comfortable that these three factors are potential factors from what we have observed so far, but it's always good to leave a space for the participant to provide their own answer so that they can address the response that we haven't considered in our options. So we always leave the other option when we're not comfortable that we're not comfortable enough to say that we have addressed all the possible options. So in this case, from the other response, we might get some large response. So from the other responses, we can have like A, B, C, different responses. And from this, let's say B could have larger response and should not be included in the other response. So we're expected to give it another code, a different code from what we have already coded. So this type of partly coded questions, they need further coding. And the third one is, I'm sorry for the mistake, the third one is completely open-ended questions. For example, if we don't have any idea about the study variable, it's better to leave it as an open-ended question so that the participants can answer on their own. So we can ask the same question, the drug discontinuation reason, as an open-ended question. So it definitely needs coding after we obtain the data. The other group is numerical variables. Numerical variables are uncoded or open-ended. For example, age. It's a very important tip is numerical variables always, this is like, I don't know, 85% of the time encounter a problem, no? So any numeric variable, actually for that matter, like any variable in its natural form, collect መደረግ ያለበት. Age ብለን we can ask like this, or we can ask like 10 to 19, 20 to 29, 30 to 39. questionናችን ላይ ብዙ ጊዜ እንደዚህ ይዘን ነው የምንሄደው, ግን this is not appropriate because the natural form of measurement scale of ages continuous numeric, not categorical. So we're not supposed to collect it as categorical. Rather, we have to obtain the data as it is in its natural scale of measurement, and then later we will categorize it. And this works for income, I don't know, weight, height, all numeric variables, laboratory values, and all other parameters that we are supposed to measure as a number. They should be measured as a number initially. So after this, it definitely needs coding so that the data can make better sense when interpreting it. So how do we code? When we create codes, what we do is for the partly open-ended questions, which is for the other response group, we are supposed to give a new code. And for entirely open-ended questions also, we're supposed to give code. For example, for the previous example, initially, እኛ ያሰብነው የሰጠነው code እንደዚህ ነበር 1 2 3 and 4 እንደዚህ አይነት ኮድ ስንሰጠው እኛ ያሰብነው from our observation, the first three are the most common reasons for drug discontinuation. ከዛ ግን እኛ ያላየነው factor behind ልናገኝ እንችላለን። ለምሳሌ religion, even እዚህ ውስጥ ካሉት ውስጥ ከcost of drug የበለጠ reason ሆኖ አግኝተናል። ስለዚህ we might need to give it a different code ማለት ነው። initially ካሰብነው 1 2 3 4 ካልነው ውጪ maybe religionን 4 አድርገን and other ብለን ሌሎቹ other reasons 5 ብለን ልናስገባ እንችላለን ማለት ነው። ስለዚህ coding partly open-ended questions, the other category መጀመሪያ እንዳሰብነው ሁሌ ላይሄድ ስለሚችል we have to cross check with it, and we might need to create new groups. And the other is for numerical values. For example, age as it is ከወሰድነው በኋላ most of the time we prefer to analyze it in a categorical form. ለምንድን ነው? Why do we prefer the categorical form for a numeric variable for analysis? What's the rationale? What's the rationale? Why do we have to categorize it? Age as it is, like 30 31 45 ምናምን ተብሎ ተሰበሰበው አለ ግን we usually categorize it for the purpose of analysis. What's the relevance of this? Interactive እንዲሆን አብረን እያወራን ብንሄድ ጥሩ ነው. It makes analysis complex. The first one, it doesn't actually. ቁጥርም ቢሆን ካቴጎሪም ቢሆን it's perfectly fine. ግን አንድ maybe እንዲረዳችሁ አንድ ኢንተርፕሬቴሽን ሰጣችሁ ለምሳሌ agent ከdisease outcome ጋር ያየን ቢሆን disease outcome the first one እንደ ቁጥር አድረስ ካደረግነው አናሊሲሱ ላይ ምንድነው የሚሆነው as age increases by 1 year the risk of dying increases by 1.02 times ሊሆን ይችላል ስለዚህ as age increases by 1 year ነው 1 year increase risk of death ላይ ምን ያህል times higher እንዲሆን ያደርገዋል ነው በዚህኛው ፎርም ግን ከወሰደ ምንድነው የሚሆነው ለምሳሌ ይሄኛው ሪፈረንስ ግሩፓችን ብናደርግ the odds of okay በሪስክ ስለጀመረን በሪስክ ቀጥል the risk of dying is 1.02 times higher among age groups of 20 to 29 compared to 10 to 19 ይላል ነው በዚህ ወይ ይሄዳ ሰይድ አሁን ምን አይነት stratified የሆነ ሪስፖንስ እናገኛለን ይሄኛው ሪፈረንሳችን ቢሆን ይሄን ሪፈረንስ አድርገን ሰራ ይሄኛው ኤጅ ግሩፕ 1.02 times higher risk አለው ይሄኛው ግሩፕ ደግሞ 2.71 times higher risk አለው ያለ ይሄዳል so ከመጀመሪያው ኢንፎርሜሽን እና ከሁለተኛው ኢንፎርሜሽን as a clinician ስታዩት ወይ as a decision maker as I don't know as a leader ስታዩት የትኛው ሴንስ ይሰጣል more it's not about the assumption now yes assumptions እንሰራለን እሺ መልሶቻችሁን ያያዩን it's very good assumptions እንሰራለን really the first one no more sense የሚሰጠው ለምሳሌ እዚህ ጋር the first one ላይ as age increases by 1 year የሚሰጠን perspective ምንድነው እድሜ በጨመረ ቁጥር risk of death ይጨምራል ነው a specific age group target አርገ ማለት resource limitation አለ we all know that so ሁሉንም age group አድሬስ ማድረግ አንችልም ለምሳሌ አሁን ኮቪድ ቫክሲን ሲመጣ በአንድ ጊዜ ለሁሉም age group አልመጣም አይደል high risk የሆኑትን ሰጣለው ተባለ healthcare professionals and 65 and above ወይም comorbidity ያላቸው ተባለ ያለ የወረደ age limit የወረደ ወደ less risk ወደ ሆኑት ማነው group of the society የወረደ ከዛ ወደ ህፃናቶች መጣ ማለት ነው አይደል so resource limitation ስላለ in terms of resource ብታስቡት የትኛው ነው targeted የሆነ intervention ለመስጠት የሚጠቅመን the first one ነው ወይስ the second one okay the second one አይደለም the second one አሁን ምን ይያለ ነው ትንሽ ሰዎችን ብቻ ታርጌት አድርገን መስራት የምንችለው ፕሮጀክት ቢሆን ለምሳሌ የትኛውን population group ነው እዚህ ጋር በደንብ ፎከስ ሰተን ማየት ያለብን እዚህ ጋር 2.7 times more risk ይላል እዚህ ጋር 1.02 ስለዚህ መጀመሪያ ይሄኛውን ከ30 እስከ 39 ያሉትን ማኔጅ ካደረግን በኋላ ነው ወደዚህኞቹ የምንሄደው ምክንያቱም ሪስካቸው እኩል ስላልሆነ ማለት ነው the first one የሚነግረን ግን በቃ ኤጅ ሲጨምር አብሮ the risk of dying from the disease አብሮ ይጨምራል ነው it's very vague so የ20 አመቱ ከ19 አመቱ ሞር ሪስክ አለው 21 ከ20 ሞር ሪስክ አለው ያለ ነው እንጂ የሚሄደው ስፔሲፊክ ኤጅ ግሩፕ ላይ ማነው እንደዚህ ክላሲፋይ አድርገን ይሄኛው ግሩፕ ሃይ ሪስክ ነው ብለን እንድንናገር አያደርገንም ማለት ነው ስለዚህ yes the second one is better ለዛ ነው ራሽናሉ ምን ከፍለው እንጂ ዴታውን ስንሰበስበው በዛ መልኩ እንሰበስበው ተብሎ አይደለም እና it's reasonable እኔም ሪሰርቾችን ስሰራ I create categories instead of using it as a numerical variable so how do we create categories it's very important ሁላችንም እንሰራበት ስለሆነ ለዛ ነው ፎከስ ያደረኩበት እንዴት ነው ካታጎሪስ ክሬት የምናደርገው do you know any techniques for categorizing numerical variables okay there are two possible techniques. The first one is using statistical methods, what we call Sturges rule. And the other is using scientific background or logic, or in other words, creating clinically meaningful categories rather than relying on the statistics. I'm a fan of statistics. I rely on statistics for my research, but when creating a category, relying on the statistics is not proper, because the statistical values could give us some clinically non-meaningful categories. So every time, if you have to classify your data, you should rely on what you know from your clinical practice, not from the statistics, because the clinically meaningful categories will give you like the normal range, the low range, the high range, and so on, so that later the interpretation of the result will give more sense and you can intervene properly. So I prefer the scientific basis for classifying your data. The Sturges rule, if you're studying MPH, you know what Sturges rule is, and since we're not going to use it, I'm not going to talk about that. So when we code, there are a few tips that we should follow. The first one is we have to give each and every data entry a unique ID. This is very important because one of the data cleaning process is avoiding duplicate entries. So we have to give each and every data entry a unique ID. Fortunately for us, since we're dealing with, most of the time we're dealing with patients, we already have a unique ID, which is MRN. So don't forget to collect their MRN when you collect data. The second one is we have to create functional or analyzable group when we code our data. For example, if you have a question, which asks which of the following symptoms do you have for your patient, and if the answers are 1 fever, 2 cough, 3 shortness of breath, 4 headache, and if the patient has, if let's say the first patient has fever, you'll tell me the answers for this. So the patient has fever, what's the code that I should be giving? Let's say the first patient 001 has fever, what code should I enter into my software? What's the code that I should give for my, yes, 1, right? So what if the patient has shortness of breath? The second patient has shortness of breath. What's the proper code? 3, great. So the third patient has cough and shortness of breath. What's the code that I should give, I should feed into my software? The patient has cough and shortness of breath. So 2 and 3. So if you are familiar with Spaces or any of the statistical softwares, for a single entry, what you can enter is only 1 code. You can't enter more than 1 code. It should be either 2 or 3. You can't enter 2 codes at a time. You can't say like 2 and 1. From the options, you can only enter 1 code at a time. So what should, thank you. We have to create dummy variables, right? So what are dummy variables? Lahum, maybe? It needs another code, but not necessarily. Not necessarily. Like cough and shortness of breath, they are like a common symptoms that can be analyzed on their own. We're not supposed to categorize everything for the sake of avoiding that. Rather than that, what we're supposed to do is we have to create dummy variables. We can do that on the software, or we can do that earlier when we collect our data by breaking down the symptom categories as questions themselves. So instead of asking which of the following symptoms do you have, we can ask the patient, do you have fever? Yes, no. Do you have cough? Do you have shortness of breath? Do you have headache? So this way we dichotomized our question based on the symptoms the patients have. So no symptom will be when the patient says no to all of the 4 questions, then that patient can be regarded as asymptomatic. So this is the proper way of collecting our data. And not only collecting our data on the software, it should be entered like this so that it can be analyzed properly. So creating functional or analyzable group is very important. The other is when we code, as you have seen so far, for binary data, I've been using like 0s and 1s or 1 and 2. Both are fine for our independent variables. We can use 0, 1, 1, 2. I mean, we can make the smallest code 0 or 1. It doesn't matter for exposure or independent variables, but for dependent variables, the coding has to be 0 and 1. Some softwares understand the dependent variable when the smallest code is 0. For example, Spaces. Stata. On Spaces, it's fine if you code the dependent variable as 0, 0, 1 or 1, 2, it reads that. But when we're doing advanced analysis and if we want to export our data to Stata, the Stata won't understand it, so we have to recode again. So instead of doing that, it's always better to anticipate all the potential change during our analysis and use the proper coding that suits every software. So when you code your dependent variable or outcome variable, make the smallest code 0. And the other is we have to create mutually exclusive and precisely define categories. For example, when we categorize age, for the software, we have to give it like this, like 20 to 29, 30 to 39. This is the proper way of coding it so that each category is mutually exclusive. If you can see this, it says 20 to 30, 30 to 40. This is not proper because if you have a patient who's 30 years old, it will be included in both groups. The analysis would include it in both groups. And if you have 40 years old patient, the analysis would include the patient in both groups. So we should avoid that, and we should make sure each and every category is mutually exclusive when we're creating categorical responses. So the other is consistent coding. Oh, I'm sorry. The other is consistent coding. Consistent coding is when we interpret our results, it will be like we label one of the responses as reference and the other will be the result that we're going to narrate. So we have to make it consistent so that our interpretation of the results will be consistent and will make more sense for the reader and for us to interpret it. So if we label fever as 0, no, 1 and 2 yes, we should label cough as the same way. If we label fever no 1 and cough yes 1, it will become inconsistent and it will mislead us eventually when we interpret the result. We will interpret it as if every code is consistent, and it will mislead us and mislead our readers. So we shouldn't do that. We should always keep a consistent coding. If no is 1, then throughout the data, if there is a no yes question, 1 has to be no, 2 has to be yes. The other consistency that we should be maintaining is 1 is not only saved for the no responses, but it's also better to code normal values as the smallest code so that later we can use it as a reference. If you have BMI and you're collecting a categorical data, then 1 normal, 2 underweight, 3 overweight, and 4 you can make it other. And when we are interpreting our results, it would be nice to interpret it as patients with hypertension as compared to those with no hypertension have a higher risk of dying from the disease, and the same patients who are underweight have a higher risk of dying from the disease as compared to patients with normal BMI. So the interpretation will make more sense when we make our references the normal one. So we should maintain this consistency, and it will make our life a lot easier. If some of you are already analyzing your data, I'm sure you understand what I'm trying to say. So we should avoid using inconsistent coding. Like here, it uses 1 as an underweight, and our interpretation will not make more sense if we code it like this. So we should stick to the normal values or as our smallest code. And the other is giving the reference category the smallest code for all variables. Reference category, I personally prefer to use to make my reference categories the responses which are coded with the smallest code. For example, here I want my reference to be fever, no, cough, no, hypertension, no, and BMI normal. So if you give the smallest code for all, your variables, then the interpretation will be easy. If we have time, maybe I can show you on day spaces after this, and you'll understand better what I'm trying to say. The other is missing value has to be always considered when you enter your data. Definitely you will encounter a missing value. When you have a missing value, make sure to give it a unique code so that it will not be misinterpreted as an actual response. For example, if you have, if for gender, you labeled 1 as male, 2 as female, you have to make your missing value code something very different from 1 and 2. And normally, actually, what's the common trend to use is like 99, 999, and something like that. So that when you see this number, you know that it's a missing value and it's not a data entry error. So it's important to give your a missing value code a unique code. So I think to make more sense, it's better to practice